way that we understand the pathophysiology and the different components of the respiratory systems, that when they are put together, it gives better understanding of how we can manage respiratory failure, intervene early when it's impending respiratory failure, and modify the different interventions that we do on mechanical ventilation. So as you see here, you have a patient who's intubated. And of course, we have different components that we need to overcome. The first thing that we need to overcome is the resistive load, which is the resistance of the airways. And you can see the spring here representing the airway resistance. And if the patient is not intubated, he needs to generate a negative pressure inside the chest in order to overcome the airway resistance. If the patient is intubated, sedated, paralyzed, you have to utilize a pressure on the ventilator that is equivalent or able to overcome the respiratory or the airway resistance. And once we get the air past the airways, we need to overcome the lung elastance, elasticity of the lung parenchyma. And again, the patient has to drop the pressure inside the chest in order to overcome, or you have to apply a ventilator a pressure that's able to open the lungs. So if you link the resistance and the elastance or the compliance, of course, is the reverse of the elastance. Elastance equals 1 over compliance. So if you combine these two physiological terms together, you get what we call the time constant. And the time constant is represented on this graph here, which is the unit of time, or the time required to exhale 2/3 of the air. So for example, if you inhale 1 liter and starts exhaling, if it takes 0.5 seconds to exhale 2/3 of the 1 liter, that means the time constant is 0.5. And the time constant simple is RC, which is a formula for it. It's resistance multiplied by compliance. So the higher the resistance, the higher the time constant. The higher the compliance, the higher the time constant. The lower the compliance, the lower the time constant. Now it is very important, because if it takes 1 time constant to exhale 2/3 of the air, actually it takes 4 time constants to exhale the remaining 1/3. So that means in patients who have high resistance, they have a high time constant, you really need to give them enough time to exhale that is actually equivalent to 4 times the time constant for that patient. And that's why those patients with asthma, they come to you with prolonged expiration, because their time constant is prolonged. And you need to allow enough time for them to exhale. And of course, if you're able to extend the lungs, the next force that you need to overcome is the elastance of the chest wall. So and this is what Dr. Iyad was actually mentioning earlier before we started the lecture. He's asking about whether the esophageal monitor would help. Actually, it will help to define those patients who have high elastance secondary to chest wall problems, such as stiffness of the chest wall, pleural effusion, intra-abdominal problem, ascites, increased intra-abdominal pressure for whatever reasons. Okay. And this 2 different loads the resistive load versus the elastance load, once the patient is intubated, you will be able actually to get so much information from the curves that we have on the ventilator. You would be looking at the initial rise in the pressure. The red here is the pressure over time, and the blue is the flow. So the initial rise in the pressure here is the pressure required to overcome the airways, the airway resistance, and the plateau pressure would be the pressure required to overcome both the elastance load and the end of the chest wall and the elastance wall load of the lungs. So the higher the difference between the peak pressure and the plateau pressure indicates higher resistance of the airway. If the plateau pressure is elevated, it means that the elastance load is increased for the patient. And then we you need to understand if you understand the resistive load that is placed on the respiratory system and the elastance load, you calculate the time constant for that patient. You need to have understanding about the gas exchange, and that is represented by the VQ ratio. And of course, I'm not going to go into details. I'm just going to bring the components forward that you need to put in mind whenever you have a patient who has a respiratory problem. And you can have myriads of different conditions of VQ mismatch. Patients who have dead space disease, all the way to shunting disease, and whatever in between of VQ mismatch possibilities. And the indicator of this mismatch would be by calculation of the AA gradient. So it is very important in every patient. We calculate the AA gradient so we can understand what VQ mismatch problem do we have with that patient, whether it is only VQ mismatch or it's shunting process or it is hypoventilation. Now, the third major load on the respiratory system is the metabolic load. And what I mean by that is actually the organs of the body, what is the metabolism, and what is the CO2 production of inside the body. And the higher the metabolic load, the higher the work of breathing the patient has to do in order to overcome or meet the demands of the body. So in patients with sepsis, for example, they have a high metabolism, they release a lot of CO2. The patient has to work hard in order to get rid of that CO2. So the load is actually from the body. There's no resistive load or elastance load in those patients, but the demand on the respiratory system is high. So this is one side, which is the load that is actually put on the respiratory system. The patient, whatever is the problem is, the patient has actually to work hard, and that starts from the respiratory drive on the other side here. So the patient has to have the respiratory drive that will fire enough respiratory rate for the patient, and then transmit through the neurons and the nerves into the muscles that they should have the strength in order to work enough to overcome that load, whether it is resistive, elastic load, or metabolic load. And this is what we call the work of breathing. And the work of breathing would be actually given to you by the formula is multiplication of the pressure multiplied by the tidal volume, of course, taken over the course of that of the duration of the inspiratory time. And it is indicated to you on the loop on the ventilator by looking at the volume of over pressure loop. So this way, you would say that I have loads on the respiratory system. This load could be resistive, elastic, or metabolic. On the other hand, I have a patient who needs to overcome that load or meet the demands of the body, which is the work of breathing. if the patient is able to breathe effectively, we will see things in balance. And this is what you see here. I put on the left side the loads that we talked about, the resistive load, the elastic load, and the metabolic load. And that would be in balance with the neuromuscular competence if the patient has the drive, the transmission, and the muscle strength that would be able to overcome that load and the body demands. If that's the case, we will see things are actually in balance, and we would sustain oxygenation and alveolar ventilation, and the patient would not go into respiratory failure. And that's what we call here, as I said, work of breathing. So based on that, we can define 4 different types of respiratory failure. Based on the pathophysiology, we would say we have respiratory failure due to increased resistance of the airways, or respiratory failure due to decreased compliance of the lungs and the chest wall combined. Of course, could be separate condition, but I made them together in this category. And the third thing would be respiratory failure secondary to inability to meet the metabolic demand of the body. And the fourth one would be the load's normal, however, the patient has a problem with the neuromuscular competence. So I'm going to take those examples one after the other. So if you have a patient with severe airflow obstruction, you can see here that the main problem for that patient would be the airway resistance. Increased airway resistance here, and the load would be the resistive load that would be increased for that patient. So of course, the patient, if he's not intubated, he needs to work hard to overcome that increased resistance. Here, if the patient is intubated, sedated, paralyzed, you need to utilize enough force or enough power on the ventilator to push the air against that resistance. Now, this could be, of course, because of asthma, COPD, bronchiolitis, could be upper airway obstruction, croup, epiglottitis, anything in the upper airways can give you increased resistance. And if you take a look on the RC, expiratory component of the RC, or the expiratory time constant, you would see that it is prolonged. The patient's time constant is higher than normal. He would need a longer expiration in order to empty the chest completely. Otherwise, you would have auto beep or dynamic hyperinflation syndrome. The elastance, if there's no any other pathophysiology or pathology in the lung, the elastance would be normal for that patient. And the VQ mismatch would be dependent. Usually it is elevated. Usually there is a decreased ventilation. Perfusion is normal. In areas of hypoxemia, you get some vasodilatation. And you would have a little bit of VQ mismatch indicated by increased AA gradient for that patient. If you take a look on the curves, you will see here that in the pink color, the one representing our condition here, the peak pressure is elevated. The initial rise in the pressure is elevated, which is the airway resistance. And the difference between the peak pressure and the plateau is increased. However, the plateau pressure is normal. If you take a look on the flow curve, you will see this is a volume control flow curve, and you will see that it's similar to the other patients because it's controlled. However, in expiration, where it is passive expiration, you will see in dotted line here that the flow does not reach the same previous peak expiratory flow due to limitation of the expiratory flow, secondary to the increased resistance. At the same time, it takes longer because of the RC is prolonged. It takes longer for the patient to exhale and go back to zero before the next breath starts. And that's what you need to pay attention to when you put the patient on the ventilator, to allow enough time to compensate for that increased time constant for the patient, so he would exhale all the way before the next breath. So with this increased resistive load, the patient would need to work harder. So the work of breathing is increased for the patient, and that is resistive work of breathing. You can see here how the patient is actually increasing his pressure to overcome that resistive load. And there's nothing wrong with the compliance of the patient or the elastance with the patient, but it is the resistive work of breathing for the patient. If the patient has increased resistive load and he has enough increased neuromuscular strength and competence, at that time the patient would stay in balance, and this is what we call impending respiratory failure. The patient is not in respiratory failure yet. In this asthmatic patient, you can see the pH 7.47, the PCO2 is 30. This is what you want to see in asthmatic patients, indicating that the patient is able to breathe effectively. The work of breathing is increased for that patient to overcome and meet the demands of the body with the increased resistive load, and the patient stays in balance. However, if the patient gets tired, or if somebody gives that patient a dose of midazolam, for example, because they're anxious, you're thinking that you're helping the patient. What you do with this, you decrease the neuromuscular competence for that patient. So he won't be able to overcome that resistive load that is imposed on the respiratory system, and at that time the patient would be having imbalanced load and competence, and he would go into respiratory failure. You can see here how the CO2 is increased and the pH is normal. So the next case that we're going to be talking about is a case with increased elastance. So with a patient who has, for example, pneumonia or ARDS, what we see here that the elastance of the lung is increased, and that could be because of alveolar edema, atelectasis, pneumonia, ARDS, or intrinsic PEEP, any of this, or of course, many other conditions can do the same. Once there's increased elastance of the lungs, at that time, the RC will be decreased. It's related to decrease the compliance of the patient. So if the elastance is increased, that means the compliance is decreased, and the time constant for that patient is decreased, meaning that it takes shorter time to inhale or exhale. This is expiratory time constant, but the inspiratory time constant would be also decreased, and the patient would take shorter time to inhale and shorter time to exhale. And what you see on the pressure over time curve, you will see that the peak pressure is increased and the plateau pressure is increased. The difference between the peak pressure and the plateau pressure is not increased, indicating normal resistance. However, the problem here is increased elastance. And on the flow over time curve, we can see that the peak expiratory flow will be deeper because it's easier to exhale, and it takes less time to exhale. You can see how the time constant is shortened, and the patient is able to exhale faster. And that's why those patients have rapid shallow breathing compared to asthmatic patients who have deep deep breathing with rapid respiratory rate, but the patient has to generate a huge intrathoracic pressure in order to inhale in asthmatic patients. However, in patients with decreased compliance or increased elastance, the respiratory rate would be fast and they have shallow breathing because they exhale very fast and the time constant for those patients is decreased. At the same time, they have an impaired VQ mismatch. Depends on the pathology, but mainly the ventilation is decreased in most of the cases with atelectasis, edema, pneumonia, ARDS, and the perfusion is normal or sometimes is increased. So your VQ mismatch is actually going towards shunting process, and of course that will be represented by an increased A gradient, and usually it is very high A gradient for the patient. Now again, similar to any other case in respiratory failure, if the patient is able to overcome that load, the work of breathing would be increased for that patient, and we will be talking about an increased elastic work of breathing rather than compared to the resistive load work of breathing that we saw with asthmatic patients. And if the patient is able to overcome that load, you will see things are in balance between the load that is here elastance load compared to the increased neuromuscular competence, and the patient would stay in balance. However, if the patient gets tired, at that time the neuromuscular competence would go down, and at that time the patient would go into respiratory failure. So the third type of respiratory failure is actually the increased demand. You can see here the organs are actually functioning at a higher rate, and the metabolic load for that patient is increased. There is no problem with the resistive load. There is no problem with the elastic load. However, there's too much CO2 production in the body. And the patient would have a normal RC. The only problem that you would see that you may have some altered VQ mismatch dependent on the blood pressure for the patient. If the patient is hypotensive, it would be decreased perfusion compared to a normal ventilation. That's why the arrow is going up. There's mismatch, but it's more on the expense of the decreased perfusion for that patient, and the A gradient would be increased for this patient too. If the patient is able to work hard, increase his work of breathing, at that time you will see things in balance between the metabolic load of the patient and the neuromuscular competence. However, if the patient gets tired, at that time the decreased neuromuscular competence will put things in imbalance, and the patient would go into respiratory failure. The fourth type of respiratory failure would be actually in the neuromuscular system. So the resistive load is normal, the elastic load is normal, and the metabolic load is normal. However, the patient has a problem. This problem could be in the respiratory drive, like patients with drug overdose, hypothyroidism, alcohol, brain tumor, hemorrhages, or whatever reason. It could be in the muscles themselves. The muscle strength is decreased because of hypokalemia, for example. Patients getting fatigued. Patient has myopathy, or there's malnutrition, or it could be in the transmission between the respiratory drive and the muscles themselves, such as patients with Guillain-Barré, myasthenia gravis, botulism, aminoglycoside use, or ALS. So if you have a patient with decreased transmission, the work of breathing that is not usually normal to overcome the normal resistive elastic and meet the body, metabolic loads, that work of breathing is less than usual. And the patient would have slow and shallow breathing because of the decreased respiratory drive and ineffective muscles that this patient would have. And of course, the AA gradient in hypoventilation would be normal for those patients. This is how you can differentiate hypoventilation from the other causes of respiratory failure. And those patients would come to you with decreased neuromuscular competence that is not there to balance against the normal, resistive, elastic, and metabolic load, and they would present to you with respiratory failure. So if we put it all together, if you have a balance between the work of breathing, the neuromuscular competence, and the different loads that you have imposed on the respiratory system, you would see things in balance, and the patient is able to breathe effectively for whatever problem he has. This load could be a resistive load, such as in any case of bronchospasm, secretions, or obstruction. It could be elastic load from the lungs itself, alveolar edema, atelectasis, pneumonia, ARDS, or intrinsic bead. It could be elastic load because of the chest wall and the abdomen, abdominal distension, obesity, ascites, pleural effusion, pneumothorax, rib fracture, or could be a minute ventilation load, such as cases of sepsis, hyperthyroidism, excess calorie, hypovolemia. So if you have any of this condition, if the patient is able to breathe effectively with increased work of breathing for him, has no neuromuscular competence that would be able to meet this increased load, at that time the patient would maintain oxygenation and ventilation. However, if he has any decreased neuromuscular competence, at that time he would go into respiratory failure. On the other hand, you may have a problem with the neuromuscular competence. You have a normal load here, but the neuromuscular competence is actually deranged. The patient is not able to maintain adequate and normal neuromuscular competence, as we talked before, impaired respiratory drive in brainstem lesions, drugs, hypothyroidism, sleep disorders, impaired neurotransmissions, in ALS, aminoglycosides, spinal cord lesions, Guillain-Barré, myasthenia gravis, botulism, phrenic nerve injury, neuromuscular blockades, or impaired muscular weakness, such as in electrolyte imbalance, fatigue, myopathy, and malnutrition. With this, I would come to conclusion of my presentation here. This is one of our workshops that we've done in Sudan, and we hope that we can organize future courses over there too. Thank you very much.
Thank you very much, Mazen, for tackling such a difficult topic with clarity and precision. The floor is open for questions. If anyone would like to ask, if you want to ask verbally, we can unmute you. Otherwise, you can write in the chat as well. Okay. So until people come forward, Mazen, I've got a couple of questions, if I may, but I'll start with, sometimes we have a patient on the vent, we suspect it is extrapulmonary or neuromuscular problem. What are the tricks that you have to assess the integrity of the muscular system or the respiratory muscles strength using the vents?
Yeah, very good question, actually. Thank you, Hassan, for asking this, actually. The respiratory drive is assessed by the P 0.1, which is how fast the patient is able to, or how low the pressure is decreased in 0.1 seconds. And we usually like to see this by 1 to 5. Anything lower than 1, meaning that the respiratory drive is decreased. Anything higher than 5 means that the respiratory drive is increased. You all working with COVID patients, if you have this capability on your machine, you have to have a very sensitive pressure monitor on the machine in order to measure the pressure in 0.1 seconds. So this is a maneuver. If you have it on your machine, it will help you. You will see that most of the COVID patients have a very high respiratory drive, and the number is higher than 5. But what is applicable to our case in the last one that we mentioned here, it would be that the respiratory drive is decreased for that patient, and the P0 0.1 pressure would be decreased less than 1. Now, the other thing is the negative inspiratory force. The negative inspiratory force would indicate the strength of the muscle. You have to have a patient who is able to inhale effectively. You will see this in a lot of patients. Again, with COVID now, after being sedated, paralyzed for a long time, you will see that their respiratory muscles are weakened, and you can assess the respiratory muscles by looking at the negative inspiratory force. If that is less than 20, that indicates severe weakness of the respiratory muscles. Between -20 to -30 is borderline. You really need to have a negative inspiratory force less than -30, meaning -35 or -40, in order to be able to cough effectively and protect the airways. Of course, the vital, if the patient is not intubated, your vital capacity less than 15 ml per kg, and the NIF can be measured in patients who are not intubated too. Thank you very much, Hassan, for this question.
Excellent. Thank you very much for the answer, Mazen. Mazen, I've got a question from Sofiani. Why the remaining 1/3 of air volume need 3 times constant to exhale?
It's the physiology of our respiratory system. It's 3 to 4 times actually time constant. That's what you need in order to exhale completely. Those are the smaller volumes in the alveoli actually that needs longer time to get the air out and exhale it. Because of the recoil of the lung, initially you can push the air faster. Within the 2/3 of the air would be pushed faster in 1 time constant, but the remaining air is actually in the small air, in the alveoli and small airways would need the remaining 3 to 4 time constant of that initial exhalation period.
Indeed. Any other questions? So we were talking before we started the session, Mazen, about the use of esophageal manometer. Do you think we can utilize this tool to differentiate between the different elastance load problems?
I think that's the main benefit of esophageal pressure monitoring, is that we would be able to assess whether the elastic load is because of chest wall versus lungs. And I just wanted to say something here. I presented this in a patient who has resistive load separate from elastic load, separate from increased metabolic load, and having enough neuromuscular competence. But in real life, what you see is a combination. You have a patient with asthma who has a pneumonia. or asthma exacerbated by an infection. You have a patient with ARDS, but he's septic at the same time. So he's got both metabolic load and elastic load. You have a patient with pneumonia and obese. So that patient would have a decreased elastic load, an increased elastic load because of the pneumonia, but also he's got a background increased elastic load because of his obesity. Patient with a pleural effusion along with pneumonia, they have both. So if you don't measure the esophageal pressure, there's no way you can estimate how much you need to overcome the elastance of the chest wall. So this is the main benefit of it, that you would be able to apply pressure to overcome the elastic load because of the chest wall, as opposed to just the elastic load from the lungs. But again, as we talked before, when you put the esophageal pressure, you measure the pressure at the site where the probe is at. So it is actually still regional. It does not measure the global intrathoracic pressure. And it also depends on the position of the patient. You change, the pressure can change in that specific area based on how you're going to flip the patient, especially now we're doing pronate position in our COVID patients too. Yeah, thank you.
That's great. Mazen, in your hand, so what was the highest PEEP you managed to get to, guided by the esophageal manometer?
Well, you're always afraid to go very, very highest, like, I know, but we increased the PEEP to 24. This is the highest PEEP I ever used, 24.
Indeed, yeah. Amazing. Yeah, one day we took the challenge and we increased it to 20, and dramatically the patient gas exchange changed, all the respiratory mechanics improved. You have to be brave sometimes, even if you don't have the machine, albeit in the right context.
Since you mentioned this, Hassan, also, me and Nabil actually once we did a tracheostomy on a patient with a PEEP of 22.
Oh my gosh!
But
that's really brave, I tell you.
Yeah, but the thing is, the PEEP was needed for elastance load. It was not needed for elastance load of the chest wall, I mean. So what you're afraid of, actually, if you lose the PEEP, the lungs going to collapse if it is actually mainly from the elastance load of the lungs. And it's very difficult to recruit. However, if you lose the PEEP, if it is put because of the chest wall elastance, it would be easily able to recruit the patient. Yes, the patient will collapse, but if you do the procedure, I'm not sure how long it's taking you to do the tracheostomy, but me and Nabil have trying to compete with each other. I was able to do it in 1 minute and 50 seconds. So, so this is actually
obviously, just talking about the cutting the skin to getting the.
You're right. Yeah, no.
Exactly.
Because you want to, without interruption without opening the airways. So once you put the scope in and you open the airways, you lose the PEEP. Once you puncture and you open the trachea to the outside, you lose your PEEP, or you lose part of your PEEP, not necessarily all your PEEP. And this is where your oxygenation may get worse. And our colleagues in surgery here, they do the tracheostomies for those patients, and there's no way you would dream if they come to see your patient if the PEEP is above 10. So us as medical intensivists, not only we know why the PEEP is put, but also we can recruit the lung in a better way than the surgeons.
Indeed. Excellent. Any further questions or comments from the floor? Excellent. It seems there's no more questions, Mazen. So
I just wanted to thank you very much, everyone. I just wanted to remind you that please register to the ICU Reach website so you can get regular updates about our activities. And we do have some interactive groups that I would like to invite everyone to join those groups. We have a hemodynamic group that is led by Dr. Hassan Hawa, and very nice interactive challenging cases been presented, and would like to also ask everyone to not only interact with the cases presented, but you can present your own cases too. You can upload, if you are a member, you can upload a case to the group, and we can all discuss it and learn from each other. There's another group about mechanical ventilation too. At the same time, if you are a member of ICU Reach, you can download most of the presentations, let's put it this way, as PowerPoint, in PowerPoint format, and you can present them to your colleagues. The idea of ICU Reach is to reach out to every person around the globe who is in need of knowledge that help in improving critical care training and knowledge. At the same time, I want to remind you that there is a workshop that is, I think, on the 13th for ventilator asynchrony. If you would like to register and attend it, I think it may be on the 13th on Saturday, but it is already on the website. And also we are planning on hemodynamic course, hopefully early January 2022, led by Dr. Hassan Hawa at the same time, and would encourage all your residents and fellows to attend this workshops online.
Thank you very much, Mazen, and see you all, inshallah, in future ICU Reach activity. We'll be reaching out to you and to your colleagues and patients, inshallah. Thank you very much.
Thank you.